Heart transplantation is palliative, not curative. It is essentially trading one disease for another. It is not permanent nor a fix and comes with many risks and medications. CHD remains the biggest reason for transplant in children. Generally, people listed for heart transplantation have a life expectancy of less than 1 year. They also tend to have significant limitations while waiting for a heart. Disqualifiers for heart transplantation are irreversible pulmonary hypertension or high pulmonary vascular resistance, active systemic infection, active malignancy or history of malignancy with probability of reoccurrence, inability to comply with complex medical regimens, severe peripheral or cerebral vascular disease, irreversible dysfunction of another organ, and diagnoses that may limit prognosis after heart transplantation. Those with Down syndrome or other syndromes or disorders that decrease the chance of successful transplant or are significantly life-limiting are almost always denied transplant. Children and parents must be compliant with medications and treatment prior to be considered for a heart transplant. This is due to the risk of failed transplant under the assumption post-transplant treatment will also not be followed completely. Overall average pediatric heart transplant wait time is 7 months. It is not uncommon to wait for over a year. Some, though not common, may wait as little as days, while others will wait several years. Wait lists vary dependent on the level of the child's needs and the level of pediatric donors. Waitlist time depends on the size of the heart needed, blood type, antibodies, and waiting status. Status 1A is the highest priority waitlist status, followed by 1B, 2, and 7 inactive. Status 1A must be admitted to the listing hospital and meet one of the following criteria. Requires continuous mechanical ventilation, requires assistance of an intra-aortic balloon pump, has ductal-dependent pulmonary or systemic circulation with a ductal patency maintained by stent or prostaglandin infusion, has hemodynamically significant congenital heart disease diagnosis and requires infusion of multiple intravenous inotropes or a high-dose single intravenous inotrope, or they may or may not be admitted to the listing hospital and require assistance of a mechanical circulatory support device. By exception, the candidate is admitted to the listing hospital and the physician believes the candidate, using acceptable criteria, has an urgency and potential benefit comparable to that of other candidates at the requested status. Status 1B must meet at least one of the following criteria. Requires infusion of one or more inotropic agents but does not qualify for Status 1A, is less than 1 year old at the time of the candidate's initial registration and has a diagnosis of hypertrophic or restrictive cardiomyopathy. By exception, the candidate is admitted to the listing hospital and the physician believes the candidate, using acceptable criteria, has an urgency and potential benefit comparable to that of other candidates at the requested status. Status 2 includes all other candidates for heart transplantation. Status 7, inactive, is when you need further tests, have certain health problems that might increase transplant risks, aren't compliant with treatment, or are staying more than 4 hours from the hospital. Waitlist mortality for newborns is 34%. Mortality for children waiting for heart transplantation continues to be higher than any other solid organ transplant. This is related to a combination of factors including availability of donor organs. Infants requiring heart transplantation have the highest waiting list mortality of any age group. Currently, there are 1,900 children waiting for an organ transplant. Over 25% are under age 5. Most children under age 5 listed for a transplant are in need of a heart. 600 to 700 pediatric heart transplantation procedures are performed worldwide each year, representing about 12% of the total number of heart transplants, meaning 88% of heart transplants are on adults. 400 of those pediatric heart transplants are performed in the United States. Currently, only about 8 to 12 newborn transplants are performed in the United States every year. Neonatal heart transplantation was developed and established in the 1980s as a durable modality of therapy for complex, uncorrectable heart disease. The need has lessened due to progression of surgical treatments. The youngest living heart transplant recipient was 34 weeks gestation, with an actual age of 1 week old and a corrected age of -6 weeks at time of transplantation. For patients who have not had prior surgery, the transplant operation takes about 6 to 8 hours. For children with prior open heart surgery, it can last a couple hours longer due to scar tissue of the prior sternotomy. Transplanted hearts undergo normal growth in diastolic dimensions, volumes, and myocardial mass over time, appropriate for body growth after cardiac transplantation in infants and children. This means the heart will grow with the child just as their own heart would. The mean cost of initial hospitalization and organ procurement was $221,897 per patient for primary transplant and $285,296 per patient for retransplant. Annual follow-up costs were estimated to be $18,141 in the first year, excluding the first 90 days post-transplant, and $18,480 per year thereafter. In the first several months post-transplant, it is not unusual for a heart transplant recipient to be on 10 to 15 medications given multiple times a day. These medications are essential for a successful transplant recovery. Multiple medications must continue, including immunosuppressants, as well as multiple medications to continue heart, lung, kidney, and immune system care for the remainder of a lifetime. It is critical that the patient adheres strictly to these regimens to avoid the many potential and serious complications of transplantation. If immunosuppressants are not given exactly on time at the correct dosage and the correct frequency, the heart can start to reject, which can result in need for retransplantation. Risks include infections, graft versus host disease, high antibody rejection, blood antigens, PTLD, pre-surgical conditions, and kidney disease or dysfunction. Kidney dysfunction is the most common secondary organ difficulty, often resulting in the need for kidney transplantation. After transplantation, patients are permanently severely immunocompromised. Any minor illness can become life-threatening, and they are more susceptible to serious illnesses. If they contract any sort of illness, it can trigger organ rejection and/or result in sepsis. The development of PTLD, post-transplant lymphoproliferative disorders, cancers, are possible to occur due to the medications needed. This is a serious cancer that needs early detection and treatment. Pediatric Heart Transplant Society data reported 5% of pediatric heart transplant recipients developing PTLD, with a probability of survival at 75% at 1 year, 68% at 3 years, and 67% at 5 years after diagnosis. Infants have a better chance of survival given ABO transplantation, with a median survival of 20.7 years. There is a belief that this is due in part to the immaturity and malleability of the infant immune system. This has allowed the evolution of ABO incompatible heart transplantation or transplantation across blood groups, which has very poor outcomes in older children and adults. Infants had better long-term survival and long-term graft survival than pediatric patients. However, they had worse short-term survival. Graft refers to the transplanted heart. Actuarial graft survival for newborn recipients is 59% at 25 years, meaning 41% or 2 in 5 will need a new heart before 25 years old. The overall survival for orthotopic pediatric cardiac transplantation is currently around 90% at 1 year and 80% at 5 years. About 50% of transplant recipients make it out more than 15 years. Transplanted hearts have an average lifespan of 12 years until a new heart is needed. Transplantation has always been about pushing the boundaries of risks in order to offer reasonable options to patients who would otherwise have no options. Heart transplantation should only be considered when all other viable options have been exhausted. A study by UNOS and the Adult Congenital Heart Association examined the outcomes of adult CHD patients undergoing cardiac transplantation. These patients represent a high-risk group for transplant because they have often undergone multiple previous sternotomies, have significant allosensitization, and often have end organ dysfunction including renal and liver disease. Waitlist mortality was lower at centers with ACHA, Adult Congenital Heart Association accreditation. Interestingly, while waitlist mortality was lower in patients with previous sternotomy undergoing transplant at pediatric centers, 30-day and 1-year mortality was higher at these centers. While the database did not provide diagnosis-specific data, it is possible that more complex patients were listed at pediatric centers. Heart-lung transplantation is performed for pulmonary vein stenosis, pulmonary hypertension, Eisenmenger's, and other CHDs involving the lungs. Bilateral heart-lung transplant is usually held off until around age 5 when survival is possible and likely, though few have been successful in young children. It is unknown why younger children cannot handle heart-lung transplants. Heart-lung transplantation in infants have a close to 0% survival rate. Only a couple cases in history have been successful being defined as survival for 1 year post-op. Heart-lung transplantation in children, in general, has very poor outcomes and limited data as they are rarely performed due to the risks. CHOP, Children's Hospital of Philadelphia, has had the most success with heart-lung transplants of children around age 5. Data shows 37% of pediatric heart-lung transplant candidates were transplanted. Only 7% recovered, 42% died waiting, and 15% were removed for another or unknown reason. A transplanted lung has an average lifespan of 7 years before a new lung is needed. This is Riley, a heart-lung transplant recipient with heterotaxy syndrome and multiple CHDs. Riley's mom, Carol O'Brien, says Riley was born April 4th, 2008 with heterotaxy syndrome and complex congenital heart disease. Riley's most complicated defect was total anomalous pulmonary venous return. His pulmonary veins went below his diaphragm and fed into his liver. At 4 days old, he had his first open heart surgery to reroute the pulmonary veins and place a VT shunt. Unfortunately, that began a battle against aggressive scar tissue. At 4 months old, Riley had failed sutureless repair. At 6 months old, Riley had his first stent placed in his pulmonary veins. By 1 year old, all 4 pulmonary veins were stented. At 1 year and 7 months old, Riley lost his first vein completely. 2 weeks after losing his first vein, Riley was listed for a heart and bilateral lung transplant. In order to try to get Riley to a transplant, we began cathing him every 6 to 8 weeks to try and help keep the remaining veins open. Riley spent over 3 years on the waiting list on 5 liters of oxygen before receiving his gift of life. Today, Riley is 13 years old and beating the odds every day. Please consider registering with Donate Life to be an organ donor. Many are in need with far too few organs available in time. Every 10 minutes, another person is added to the national transplant waiting list. One donor can save 8 lives and improve the life of 75 others. Every year, 16% more children are in need of a transplant.